Noswaith Croeso. Good evening and welcome, everyone. It's our great fortune that we have Professor Dame Theresa Marteau from Cambridge University joining us this evening. Professor Dame Theresa Marteau is Director of the Behaviour and Health Research Unit in the Clinical School at the University of Cambridge and Bi-Fellow in Psychological and Behavioural Sciences at Christ's College, Cambridge. Her research interests, currently funded by the Wellcome Trust, include the development and evaluation of interventions to change behaviour, principally diet, tobacco and alcohol consumption, in order to improve population health equitably and sustainably, with a particular focus on targeting non-conscious processes. Risk perception and communication is another of the research interests of her group, particularly biomarker-derived risks and their weak links with behaviour change. And then finally, the acceptability to publics and policymakers of government intervention to change behaviour. Theresa co-chairs the Lancet Chatham House Commission on Improving Population Health post-COVID-19, focusing on identifying key actions for equitable and sustainable improvements in health. Theresa also currently participates in the UK government's Scientific Advisory Group for Emergencies, many of you know as SAGE, responding to the COVID-19 pandemic, and in particular two SAGE subgroups, the Scientific Pandemic Insights Group on Behaviours, SPIB, and the Environment and Modelling Group, EMG. Theresa, it's an enormous pleasure, as I've already said, to have you here this evening. Many thanks indeed. Over to you.
Thank you very much indeed, James, for that introduction. And it's a great pleasure to be here with you all this evening. What I want to do is to talk about 4 sets of behaviours that contribute most to our health, or rather our poor health. And as you can see, the 4 sets of behaviours which are in the top 10 of the risk factors for premature death, poor health, and health inequalities, contributing to the 8-year gap in life expectancy between the richest and the poorest, and the even larger 18-year gap in the number of years that the poorest and the rich can expect to live in good health. I want to start by asking everybody to reflect on 2 questions that I'm going to touch on throughout my lecture to raise the question of why we aren't doing better at changing these behaviours to improve our health. So why, despite our annual resolutions and numerous government policies, does our weight collectively as a nation continue to rise and levels of physical activity fall? And why more so for those living in the poorest neighbourhoods? And the second question to reflect upon is why 6 decades after the landmark Royal College of Physicians report in 1962, marking tobacco out as the most lethal legal product, is smoking still one of the largest causes of premature death and gap in life expectancy between the rich and the poor. There is no one answer to these questions that I've posed, but I hope that I'm going to touch on some of the causes of that situation. So what I want to do is just to give everybody a snapshot of where we are at the moment in terms of the main behaviours that are contributing to those 2 questions, and then come on to talk about changing behaviour and in my title, 5 ways to improve health for all by changing behaviour equitably, and then raise a question about the future. So if we look at weight in England, or rather overweight in England, on the left-hand side, you can see the figures for the last 30 years for rates of overweight and obesity in men and women. And you can see that these have stayed high, with the majority, around 63% of the population, now overweight or obese. And then further over, you can see the rates in children. And this is age 10. These are recent figures. And during the pandemic, the weight of children, and indeed on adults, I haven't updated the figure on the left, has increased. So almost 41% of children aged 10 in England is now overweight or obese. But importantly, you can see that this is lower in the children from the least deprived areas of England, where around 28% are in that category, compared with almost double, 50%, in those in the most deprived areas. Now, two sets of the behaviours that contribute to obesity: excess consumption of energy-dense foods and physical inactivity. And for adults, alcohol also contributes. For those who drink, it's between 5 and 10% of the energy that adults consume. And just looking at physical activity, I'm showing it in children, but a similar pattern in adults. Recommended daily amounts, around an hour of physical activity, play being the largest group of physical activity for children. Around 45% meet those guidelines. And importantly, again, rather like weight, it's patterned by affluence. So you can see that in the more affluent families, around 50% are meeting the guidance, compared with 39% in the least affluent families. And there's also a patterning by ethnicity, with white British children being more physically, a greater proportion meeting these guidelines compared with those who are from Black groups. For smoking, the picture is more, I think there's more evidence of effectiveness and success. If you look at the rates of smoking in men and women since the 50s, they've really fallen in a very significant way, due in no small part to effective policies. But if we look at the rates today, with the latest figures, what you can see is that there is this strong patterning, so that those in the poorest households are around 2.5 times as likely to be smoking as those in the highest income families. So I want to now move on to think about changing behaviour and, as I say, more and less effective ways of trying to change behaviour across populations. There are numerous models, different ways that psychologists and others have understood our behaviour for more than a century. One recent paper estimated that there are over 80 different models of behaviour in the context of health. So this is a very stripped bare model, which I think is very helpful, which allows us to think about an individual's behaviour as being a function of the individual, the person, what they bring to a situation, their history, personality, motivation, also their biology, and the environment in which they're living and the behaviour is going to occur, the physical and social surrounds. And these all interact. I'm going to start by focusing on interventions that have targeted the person, and in particular, information-based interventions. Now, most of the models have elaborated in particular on different aspects of individuals and their motivation. And indeed, much policy that we've had for changing behaviour has also focused on, if you like, trying to change what's inside our minds in order to change our behaviour. And there is this it's still a very strong idea that what we're seeing is very often a motivational deficit, and that if somehow we could motivate people, this would lead them to change their behaviour. So I'm going to talk about the first important way of changing behaviour, which is not to fall into what I'm calling the risk information trap, which is to believe it's just a matter of presenting individuals with the risks to their health from their current behaviour, and that will lead them to change. Government campaigns to change our behaviour, not just in the context of health, have been running for over 100 years. And these are important in terms of being able to communicate the risks inherent in our behaviour. But while they have some effectiveness at raising awareness of the risks, when it comes to actually changing behaviour, at best, the impact is minimal. So that's led people to raise the question, well, maybe if the information were personalised, because this is sort of very general and people can exclude themselves from it. And one of the ways in which people have looked at personalising risk information is to use biological markers and to combine them with other information. One set of biological markers that has proved quite popular is genetic tests, in order to reveal that which is hidden from individuals. And this is just one example from a testing kit that you can buy online, not that I'm proposing that you do. And in this particular advertisement, it's suggesting that you could find out through, in exchange for, I think it's $100, a saliva sample, the chances that you might develop type 2 diabetes, whether you're at lower or higher risk. And so the important question is, does this kind of risk information personal to you change our behaviour? So would, for instance, finding out that you had an increased risk of type 2 diabetes lead you to increase your levels of physical activity or to lose weight? So we looked at this in 18 randomized controlled trials and brought them together. And what we found was that when communicating genetic-based disease risks, this did not result in a change in people's behavior to reduce those risks. And we looked at, amongst others, the 4 behaviors that I've flagged up that are most important in influencing our health. Now, you might think, well, that's because it's genetics and people may well feel a sense of helplessness. I can't change my genes, so why should changing my behavior change my risk? But this pattern is also seen in other reviews that have looked at different kinds of biological markers, not just genetic ones. And the result is pretty much the same, that there's little or no behavior change when people are given information about their risks of a future condition for which they could reduce their risk by changing their behavior. So why not? Well, I think a large clue is in these pictures. It's not that we're insensitive to information. It's just that it depends really on what the information is about. So you can see on the right-hand side, this is generally extremely effective information, warning people about sharks in the sea. This is an immediate threat that's probably incompatible with seeing the end of your day, as opposed to the kind of information that we're talking about with the behaviours that increase the risk of chronic non-communicable diseases, cancers, type 2 diabetes, where changing your behaviour may well reduce your risk of developing it, but there's no guarantee, and very often you're being asked to give up a behaviour that may well give you certain pleasure. So in short, the threat isn't perceived to be big enough. But where people do perceive the threat to be big enough, even so, even if they're motivated to change, I think that the main answer to the question about why risk information isn't changing our behaviour is because environments have a strong influence on much of our behaviour, and much stronger than many of us would like to believe. Now, it is important, of course, I'm not saying that all risk information or all information is ineffective at changing our behavior. That is not the case. And what we do know, though, is that often information-based interventions can be more effective in those who are least deprived. So the example I'm going to give here is a recent systematic literature review, and I'm not expecting you to read or understand this, but this was a review that brought together all the studies that looked at digital interventions, wearable devices like Fitbits, to ask the question, does it increase physical activity? And what they were able to do in this review was to look at what's the impact according to whether somebody was in a higher socioeconomic status, so a more affluent group versus a less affluent group. And in the more affluent groups, it surely did have an impact. It did increase their physical activity, but for the least affluent groups, it had no impact. So what that tells us is that if one introduced that expecting to reduce inequalities, in fact, it would paradoxically increase them because it's helping one group but not another. Why? Well, they didn't look at that in the review, but the next two things I'm going to talk about, I think, give us some clues about that. One is about the different physical environments in which people from more and less affluent communities are living. And the next one is about poverty. So I'm going to start with the environments in which we live. And as I've already said, environments shape our behavior, but often without our awareness. And here are just a few examples of cues in our physical everyday environments that shape our behavior. So the size of the drinks or food, which have changed dramatically over the years, that will affect how much we're consuming. The high streets, the kinds of fast food outlets that are there. And also what the street is like when you open your front door. The left-hand side showing sections of the North Circular Road and the right-hand side showing a leafy cul-de-sac. What I'm going to do now is to show you some evidence from a range of experiments that have looked at the relative impact of the power of environments over information targeting individuals to try to get them to change their behavior in order to make more vivid the points about the power of environments in shaping our behavior. So this first study conducted 4 decades ago, and what they were interested in was increasing physical activity by getting people to use the stairs rather than the lifts. So on the left-hand side were the first set of interventions they used, which was about having messages on the side of the lift saying, as you can see here, electricity consumed by users of the lift in the preceding week versus previous best record, to try to appeal to people's competitive spirits. And then there was a much more bold statement, an instruction: save energy, use the stairs for short trips. And they were able to see that had no effect, neither of those had an effect on lift use. But when they changed the environment, so when they made the lift less convenient to use by slowing down the speed at which the door was closed, then people were more likely to use the stairs. They had to put a notice by the lift to say this lift is not broken, because people spent quite a bit of time phoning the engineers rather than using the stairs, thinking the lift was broken. So that's just one example. Another example comes from a series of studies in my group that we've conducted looking at worksite cafeterias and trying to reduce the amount of energy that those using the worksite cafeterias are consuming from their food. So what this is showing across 6 work sites, a change in energy purchased. So we looked at all the food that went through the till and translated it into the calories that were purchased. Before and after the introduction of calorie labelling. This was in a step wedge design for those of you interested in designs of the studies. And when we collapsed across the 6 sites, we saw that there was no change in the energy that was purchased as a result of calorie labelling. But you'll see that there was some variation across the sites. We then repeated in another study and similarly no effect. But by contrast, when we looked at what I would call changing the environment, so we changed the food that was offered to people in a different set of worksite cafeterias. So we changed the proportion of higher energy food. So 3 out of 4 main meals were changed to 2 out of 4 that had higher energy and 2 that had lower energy. And we also changed the portion size. We reduced it by about 10% for the higher energy food. And this is a very messy slide coming up, but I just want you to focus on the summary across 19 worksite cafeterias. And when we just look at the availability intervention, then you can see that the amount of energy that was purchased in those cafeterias went down by 4.5%. And when we added to that, reducing the portion size, then the 2 interventions together reduced the energy purchased by around 11%. And the footfall was the same. People weren't complaining about it. So this seemed a relatively easy way by changing the environment to change what people were consuming. Sticking with portion size, to what extent? So this has been shown in many, many studies, what's called the portion size effect. So in short, the larger the portion in front of people, the more they will eat, and often without awareness. So one of the questions is, to what extent, if you tell people about the portion size event, will that mitigate the effect? So to what extent is this happening outside of awareness? So in so in a study, they examined this where they randomized it with students to one of 2 groups, either a control or a group who were told about the portion size effect. So in the education, they were given information about it and how to overcome it, how to resist being given a larger portion. And then those 2 groups were randomized again to be given a large portion of pasta for lunch or a small portion. And what you can see here is that with the large portion, regardless of whether the students had been told about the portion size effect, the students in both groups ate 34% more. So this is just an example of how people, not always, but in the main, the environment is having a larger effect on our behaviour than we can address by informing them of that. So just wrapping up on these, what I will call small cues in everyday environments, just looking at alcohol. We know there's been less research on this, but we know that alcohol comes in various sizes and both in terms of bottles, cans and glasses. And while we know that plate sizes have increased over the last century, we didn't know much about wine glasses, but in a study led by a student, we were able to document over a 300-year period in England that the size of wine glasses has increased almost 7-fold for a variety of reasons, which we can come on to in discussion. But the key question is, does that affect how much we're drinking. And in a series of experiments that we conducted in bars and restaurants, what we found was that in bars, it didn't have a significant or reliable effect, because in bars, in the main, people are served, regardless of the size of the wine glass, in regulated portion sizes. But in restaurants, where people are more likely to be drinking from bottles, what we found was that compared with a 300 milliliter wine glass, when the restaurants used, and this is all in experimental design, 370, a slightly larger glass, then sales of wine were increased by just over 7%. And in separate laboratory studies, we've shown it's really the portion size effect. So when people have a bottle and they have a range of glass sizes, the larger the glass size, the more they pour in. And as is documented, well documented for food, generally within quite a wide range, people will consume what they are given. So that's the effect there. So zooming out a little bit to look at the built environment and looking first of all at how these vary by affluence and deprivation. Fast food outlets, there's a very strong correlation between how deprived an area is and the number of fast food outlets. So the more deprived, the higher the density. And there's also separate work showing that the more deprived an area, then the greater the availability of cheaper tobacco and also cheaper alcohol. So those who are more deprived are living in areas where there are more queues to purchase products that undermine health. And over the last couple of years during the pandemic, we've all become very well aware of the importance of outside space and green space. And people have now started to document how this again is socially patterned. So there's more green space, the more affluent an area. And it also varies with the ethnicity of populations as well. And the greener the space, the more likely people are to be using it to play and to be physically active, with benefits for mental health as well as for physical health. So this gives you some idea about how environments are shaping people's behavior differently according to where they live. I just have one slide on the economic environment, what I'm calling the economic environment, which is incredibly important in shaping our behavior in relation to the three sets of products that most harm our health. So in relation to tobacco, alcohol, and sugary drinks, what we know is that some of the largest impacts come from these so-called health taxes. And what we know is that the less affordable products are, then the less likely people are to buy them. And this is showing the affordability of tobacco, apart from a blip in the 80s, policies of the British government have been to increase the price in real terms each year. So you can see the affordability has come down. But in a recent report by the Royal College of Physicians, where they're noting that government is not on track for eradicating smoking by 2030, they recommended that the affordability needs to be brought down much more. First of all, by having an equivalent tax on hand-rolling tobacco and cigarettes, because at the moment it's cheaper to smoke using hand-rolling tobacco than factory-made cigarettes. And they recommended doubling of the price of all products over a 5-year period. So health taxes, as it says on this report, do save lives. And before I leave environments, I'm going to zone out even further for those of you who work in this area and interested in more detailed analyses of what can change behavior. I've really been talking about what's available in our physical environments. And this was a review a group of us conducted looking at tobacco control, alcohol control, food and physical activity. I've just mentioned fiscal and economic environments, and also marketing is important, both restricting advertising as well as marketing services that can help those who are addicted to tobacco, as one example. So I want to come on now to think about a completely different set of factors that may be shaping behaviour, and looking in particular at poverty as another factor, as well as a difference in environments that might be explaining some of the difference in the patterns of behaviour and the different outcomes, health outcomes. So Michael Marmot has published several very influential reports where he has attempted to describe the gap in health between the richer and the poorer, and what factors have contributed to that and what the policy implications are. So working with Michael Marmot, we conducted an analysis to look at the extent to which, if one addressed what are sometimes called the social causes, of which family income is one, would that change behaviour in and of itself? And we were interested in particular looking at what evidence there was for poverty driving some of these behaviours. And there's very little evidence, but we did find a little bit of experimental, natural experimental evidence, which looked at what the impact was of increasing household incomes amongst the poorest households. And what they showed was that this led to or was associated with an increase in spending on fruit and vegetables. And what hadn't, many people would not have predicted, is that it also reduced how much those households were spending on tobacco and alcohol. So these are just small increases in household income. And it's thought that it might be working by alleviating stress in those households. Now, completely different evidence that would support that explanation comes from a series of elegant natural experiments from a group in the States, where they looked at Indian sugarcane farmers before and after their harvest. So it's good to have a natural experiment where you've got the same people before and after, when they are poor and they really are on their uppers, and when the money comes in. So what they showed in these studies, and I should say that people weren't hungry when they were completing these tasks, was that after the harvest, where the family is clear that they have good resources again, is that certainly their accuracy on these tests goes up, their reaction time is lower, and they make far fewer errors. And what I would say is that for those who are in poverty, and unfortunately, that's a growing group at the moment in the UK. Their priority is about getting from one end of the day to another, and their ability to focus, for instance, on the environments that are cueing them to engage in unhealthy behaviours means that they are much more susceptible to those environments. Now, what we also concluded in our analysis was that certainly alleviating poverty, I mean, there are many reasons to alleviate poverty, but one of them is that it has a positive impact on people's health-related behaviour. But that is not enough, that one also needs to change the environments that I've just talked about. So why aren't we doing all these things? I just want to end this lecture by thinking about some of the barriers that there are, particularly to changing the environments, including putting up taxes, as well as shifting what is in our high streets, and focusing both on businesses as well as on the public. So a book, actually there is a film too by Oreskes and Conway, The Merchants of Doubt, published in 2010, which was a landmark book describing particularly what the tobacco industry and the fossil fuel industry were doing to create doubt, both casting doubt on science and also the scientists, in order to stop effective policy making. I've got some examples of material used by the tobacco, alcohol, and drinks, soft drinks industry at a time when government was considering policies that would have been effective in reducing sales of their products, say standardized packaging of tobacco. This was a poster campaign that was issued at the time when government was consulting on minimum unit price. This was a campaign, and when government was considering the soft drinks industry levy. So communicating, attempting to persuade the public that what government is planning to do is not necessarily in their best interests, but there's also lobbying that goes on, lobbying of politicians to try to stop these policies. And in 2021, in a report I've already referred to from the Royal College of Physicians, looking 60 years after their landmark report from 1962, well, almost 60 years, they stated that the tobacco industry interference in tobacco control has been identified as the greatest obstacle to the implementation of evidence-based measures to reduce tobacco use. And I would encourage those of you who are not familiar with this to read the case study in this report on the attempt by the tobacco industry to put pay to the standardized packaging of tobacco products legislation, which eventually came in 2016. I think it is, I was involved in that, and I still find it shocking to read how much undue influence they continue to have. So what can be done? So just here a list of some of the actions. Some are already enshrined in regulation, but we need to be much better at protecting effective policies from industries that stand to lose. I mean, I'm not saying it's all industry, but it's some parts of industries that stand to lose if effective policies are introduced. Now, the public also has a very important role to play in terms of influencing policymakers, because one of the main factors affecting the acceptability of policies, and that's what we need in order to change environments, in order to change behaviour. One of the main influences for policymakers, for politicians, is how acceptable the public find these kinds of interventions. And in a report published in 2007 by the Nuffield Council, they described different levels of intervention. I've talked about some of them. So providing information to people to change their behaviours, providing services, changing the defaults, the kind of healthiness, relative healthiness of food, taxation, restricting and eliminating choice, such as banning smoking in public places. So generally, the public find it, they're very happy, they find it very acceptable for governments to have campaigns, provide information, but they find it much less acceptable when governments are talking about taxation and restricting choice. And they also perceive information to be pretty effective. But the inconvenient truth is that generally the higher up you go, the more effective the interventions are. So we were interested to know, could we align public perceptions of acceptability and effectiveness if they were given evidence that actually what they think isn't very effective and isn't acceptable is much more effective. And it's a very busy slide, but if you just look on the right-hand side, what we did was that we pulled together, we found 36 experiments that had asked that question. 20 of them had looked at health, 9 at the environment, and then 7 had looked at education, gun control. And what they compared was how acceptable, how much support there was for a policy when either they were given evidence of its effectiveness, or they were just told that this can be effective. And overall, what this the pooling of the results showed is that indeed public support is increased by an estimate of about 4%. Now, it doesn't sound very much, but as we all know, referenda are won and lost on less. So 4% can be really quite important. And critically, when people were given information or given evidence of ineffectiveness, then their support decreased by a similar amount. So I think it's a good news story that people are sensitive to evidence of effectiveness of policies. People like policies that work. But of course, it's a crowded space with a lot of other information that people are being confronted with, and some of it misinformation from industry. So finally, that it's pretty passive giving people information. There's much more interest now in engaging publics and communities in conversations and evidence about policies that are going to affect their lives. So citizens' assemblies, we had one recently in the UK on the Citizens' Assembly UK, which unfortunately was caught up in the pandemic, so I don't think received the publicity that it should have done. But there have been several of these citizens' assemblies, one in the Republic of Ireland and in France. And generally what they tell us is that citizens are far more ambitious in terms of the stringency of the policies they want to go for than seem to be our politicians at the moment. Those are very cumbersome and can be very resource intensive. And I think that over the coming years, we're going to become much more agile, and probably the most agile community or country is in Taiwan, where their digital minister, Audrey Tang, has led the way in terms of having platforms that can engage the public, where they are debating and also shaping policy there. I think over 50% of the population in Taiwan has taken part in some of the exercises for gaining their input on government policy. So I very much see that as the future and engaging publics and communities. So coming back to the 2 questions that I posed at the very beginning and haven't addressed in detail, but I hope that I've given you some idea that some of the answers to both those questions are seen in what I've talked about. So arguably the policies so far to date, particularly for in relation to obesity, have focused too much on information-based interventions, for not enough change in the environments. Poverty, as I've already mentioned, has not been alleviated. In fact, it's growing. There's been some attempt to stop businesses, but that is a major threat. And engagement of the public is starting, but with more engagement, we may well see much more effective policies. So the future. We have coming down the track the Levelling Up White Paper with its 12 missions, and mission 7 in health is to, in 8 years' time, to reduce the gap in healthy life expectancy between local areas where it's highest and lowest, and by 2035, healthy life expectancy to rise across the population by 5 years. Now, I don't doubt that some of the people who are attending this lecture from the University of Cardiff would have contributed or will be contributing to this, because the detailed policy papers are being drafted as I speak. They will have contributed indirectly through evidence that they have published, and some of them may be taking part in some of the consultations that government is conducting at the moment, which is great. And going a little further into the future, I'm hoping that any undergraduates and sixth formers who are here this evening, importantly, will be shaping our future, both in terms of their voice, demanding more and better policies, particularly when we're looking at net zero 2050, and also becoming scientists and members of parliament, because this is where I think that we need to be seeing much more change. And I think all of it primed by the excellent initiative of the Cardiff University public lecture series. So thank you very much.
Thanks very much indeed, Theresa. Thanks very much for your kind comment at the end as well. I'm sure we do have a good number of sixth formers and undergraduates attending this evening. So an inspiring thought. Fascinating talk there, Theresa. A number of quite shocking facts and statistics as well. I was just wondering if we could get our audience to maybe start placing some questions in the Q&A, and if I could just start things off. Theresa, the New Zealand government are taking a new kind of route to reducing the number of individuals smoking in that country. I don't know what your thoughts are on that policy, and whether it's something similar you think might come about in the UK as well. I'm alluding to the policy where they're stopping individuals from being able to buy cigarettes at certain ages, and that age is rising year by year. So effectively, teenagers are never going to be able to be legally buy tobacco.
Yes, it's a policy that's been floated here over the years, but we haven't done anything about it. So I think that's an excellent initiative, and definitely we should be doing more. So we've got, if you like, we can divide it into two challenges. One of them is to stop children from starting, and that's what that policy is aimed at.
Yes.
And the other is to enable those who are already smokers to stop. So I talked about the importance of significantly increasing the price of tobacco products. And I didn't mention the other side of that, which is to reduce the price of e-cigarettes and other products to enable those who are currently still smoking to stop.
Yes, thank you. We've got our first question come in. Do you think political ideology plays a part in politicians not adopting bolder policies, such as heavy taxation, while adopting less effective policies, e.g. calorie labelling?
I think it's a really good question. I am increasingly concerned about the gap between the evidence and the policy. And I think that maybe there are two things, or actually several things that are playing into that. Yes, these are political choices. And I think that the policymakers are, as I said, they're being shaped by publics who may be resistant. But I think my reading of it is that publics are less resistant than politicians might be reading into it. I think we've also seen a failure of evaluation. So we've had some extraordinary aspirations. So there's an aspiration, I think that's what it's called, ambition, to halve childhood obesity by 2030. And we've had any number of policies. And if one looks at that ambition, which is laudable, and then one looks at the policies, it's incredible. There's no way those policies can meet that ambition. Whereas if in policy making, those who were designing the policies were obliged to go through a system of evaluation, which is recommended in the government Magenta book for evaluation, then we would have policies that stood a chance of meeting the ambition. So at the moment, we've got a gap between the ambitions, which are really good, also to eradicate smoking by 2030. That's brilliant. But we need policies like New Zealand, not like the ones we've got at the moment.
Yes.
So that's my concern about levelling up, that we've got this great ambition, but it's going to need all the policies I've mentioned and more to achieve that.
Yes. And the current economic shocks that we're experiencing as a result of post-pandemic and the war in Ukraine, I guess that's just going to exacerbate where we're at the moment. Is that you must be quite worried about what's happening at the moment.
Yes, and also Brexit, of course, and that having an impact. I mean, the concern is today, I think that George Eustace, Secretary of State for DEFRA, I think was reported as saying that with the cost of living crisis, that some of the obesity policies, such as the removal or the banning of buy one, get one free, was not, they were thinking about not implementing that and several other policies. So I think that there's a real concern that some of the longer term policies for health and also meeting net zero are going to get caught up in this. There are choices, I think, political choices, which of course, as a researcher, those are not the choices I'm faced with making, but it's not inevitable, I think.
Back to tobacco issue, doesn't anti-tobacco legislation have to be aligned with reducing use of other drugs? Would you like to comment on that, Theresa?
So I'm not sure what that's getting at. Is that implying that a sort of hydraulic model, that if people are not using tobacco, they'll go on to other drugs?
Potentially, I suspect that's what it is, yeah.
Sure. Yeah. I think it's a good, so I don't think the two have to be tied together.
Okay.
Yeah, but it's important to have policies in both.
Yes.
But what we do know, as I was saying, that tobacco remains one of the largest single factors that's driving that gap in the number of years lived and years lived in good health. So it remains right up there. So tackling tobacco is absolutely, that's the number one thing to be doing.
Yes. Governments are very slow to act on scientific medical evidence and seem to be overly concerned too much about the economic impacts of possible actions that should be taken. Any comments or advice?
I think it's a good observation. I recall in the response to the consultation on minimum unit price, which I think was published in 2013, the concern was about the nighttime economy. Mm-hmm. And I think the question comes, very often we can see health and wealth being traded off, but it's not the people who are getting wealthier necessarily. And so certainly with regards to minimum unit price, there was a very interesting investigative journalist who looked at the amount of lobbying that happened in government over that period. So my sense is that it's more lobbying that's going on rather than anything else from those industries who can be quite close to government. So I think protection from lobbying would reduce at least some of that.
Yes. To what extent do you think current health behaviour research considers vulnerable communities, such as those with disabilities that restrict their ability to exercise, or those unable to diet due to eating disorders?
Yeah, I think it's a really good question. So I've been talking, because this is what I've been looking at a very kind of gross level, but I think it's a really good question. So there are many vulnerable communities, just thinking in terms of tobacco, those who have mental health problems, who high, disproportionate number who smoke and who will die early as a result of that. So I think it's important that, particularly when we're looking at levelling up and reducing inequalities, that we don't just think about it as I have rather crudely been presenting it this evening in terms of those who are more and less affluent. There are many other ways in which people are vulnerable, and those groups also need to be woven into any coherent policy and strategy. Indeed. So it's a good point.
Thank you, Theresa. Yeah. So the data you presented this evening on size of drinking glasses was quite sobering for me, and I think I'll be reviewing the size of the drink glasses in our kitchen cabinets. What about plate size? Have you looked into that? The impact of that on sort of eating in restaurants and or just in the domestic household?
So the evidence on the evidence on plate size is more mixed, I would say, than it is certainly from the work that we've been doing on wine glass. And I think because it's my reading of the evidence is that it's there are many factors that contribute. So there's the size of the serving bowl, there's the size of the utensils, there's the size of the plate itself, And so in some reviews, depending on what evidence they've taken in, there is an effect, and in others there isn't. So it's more mixed.
Great. Theresa, there don't appear to be any more questions, so I think it just remains for me to thank you once again for summarising a huge body of work for us this evening, conducted over many years, that is playing a very important part in our in the lifestyles of individuals in this country and elsewhere. So many thanks once again for a really superb presentation this evening that I'm sure has been much appreciated by our audience. I'd just like to call upon my colleague, Karen Edwards, for a moment, who's going to try and capture some feedback for us this evening. So Karen, over to you.
Thank you, James. And yeah, thanks to Theresa as well for a great lecture this evening. If you just bear with me a second while I share my screen. Hopefully you can see that. So for those of you who've been before, you'll know that we usually do this at the end of the presentation. So if you can go to Mentimeter and enter the code that is at the top of the screen there. And yeah, first question. So where are you joining us from today? So if you could let us know. Great. Okay. Okie doke. Mostly Wales. Welcome to our English participant. Okay, while you're sort of catching up and voting on that one, I'll just move along to the next question. So have you attended a Science and Health public lecture before? Okay. Great. Mostly attended before. Good to see we've got some new attendees this evening as well. Thank you. Okay, so where did you find out about this evening's lecture? Okay, that's great. Thank you. Okay, so why did you attend the lecture? Okay, mostly to be informed and inspired, and I'm sure you will have been. Okay, lovely, thank you. And as a result of viewing the lecture, it's good to see that most of you say that your knowledge of the subject matter has improved and you'd like to find out more. That's great. Okay, so could you just give us 3 words to describe your thoughts on this evening's lecture? Yeah, certainly were shocking statistics. Yeah. Insightful, yeah, interesting, informative. Great. That's it. Thank you very much. I shall just hand back to James to let you know what we've got coming up for a very last lecture of the series next month.
Indeed. Just our thanks once again to Professor Dame Theresa Marteau for an outstanding lecture this evening. And to remind everyone that we're back again for our final lecture of the series this year on Thursday, the 7th of April. Dr. Chris Williams from Public Health Wales will be giving a talk entitled From Literature to Lockdown, Using Science to Respond to Pandemics. So I hope to see many of you again next month. Thank you now. No star. Good night.